Hi, I'm Dr. Stephen Archer. I'm the Chief of Cardiology here at the University of Chicago, and I'm interested in pulmonary hypertension, both basic mechanisms and treatments. My colleagues and I have a paper that will be coming out soon in the New England Journal of Medicine dealing with the use of phosphodiesterase inhibitors in the treatment of pulmonary arterial hypertension, and this interview will discuss that and other treatment options. Pulmonary hypertension is an interesting syndrome. It's important to recognize that the World Health Organization has 5 classes of pulmonary hypertension. The type that there are specific therapies for is class 1. So category 1 pulmonary arterial hypertension used to be called primary pulmonary hypertension. The other 4 classes are much more common, and this is important. So, for example, category 2 is pulmonary hypertension associated with left heart disease. Category 3 is pulmonary hypertension associated with lung disease or cor pulmonale. As you can imagine, if you include all those categories, that's a lot of patients that are affected. And the definition of pulmonary hypertension is simply a resting mean PA pressure, pulmonary artery pressure of more than 25 millimeters of mercury. When the first step in the is in fact getting an accurate diagnosis of pulmonary arterial hypertension. This involves excluding the other 4 categories of pulmonary hypertension. So we have to first make sure there is no left heart disease, valvular disease, lung disease, thromboembolic disease, or hypoxia. Once all that's done and you're sure the patient in fact has pulmonary arterial hypertension, by which point they should probably be seeing someone like my colleague, Dr. Gomberg, who runs a pulmonary hypertension clinic, at that point then you can think about therapy. And this is where we divide the patients up based on their functional class. So the evidence-based guidelines for treatment of pulmonary hypertension are based on how sick the patient is, and we have different treatments for the highly functional classes of class 2 and 3, and the less functional classes, the patients who are class 3B and 4. The specific therapies that we use for those classes are as follows. If you're talking about a patient who's class 2 or 3, so they can walk, say, 400 or 500 meters in 6 minutes, which is a common test that we use, that person is a candidate for either an endothelin antagonist or a phosphodiesterase 5 inhibitor. An example of an endothelin antagonist would be the drug Bosentan. An example of a phosphodiesterase inhibitor would be sildenafil or Viagra. Therapy that is in the background, in addition to, we call that pulmonary hypertension specific therapy, but in the background we have some other therapies going on. So if they have a little swelling in their legs or edema, we use Lasix. If their oxygen tension is less than 90 millimeters of mercury, they might get supplemental oxygen. And if they have evidence of some right heart failure, they might get digoxin. It's interesting that neither digoxin, warfarin, or Lasix have any evidence for them. They're empirically based therapies that are commonly used in the background. One very important point in managing patients based on their functional class is that patients that are really sick, class 3B and class 4, not only are very debilitated, they can't walk very far, and they're in right heart failure, which is actually what kills people in pulmonary hypertension, is the right ventricular failure, but they also are at high risk of dying relatively quickly. And because their mortality rate is extremely high, it's critical that these patients not go through oral therapies before they get definitive therapy. So if someone's class 4, we would start them on Flolan, which is a continuous intravenous prostanoid. And this is somewhat cumbersome. Flolan uses a central line that delivers the prostanoid continuously via pump. It requires a patient that is well educated, highly motivated, and a physician and team of nurses that are really rigorous. But nonetheless, if they're class 4 patients, they need to get that therapy first and foremost. In fact, that's the only therapy that in a randomized trial has been shown to prolong survival in pulmonary hypertension. Now, fortunately, even for the class 4 patients, there are some new options. Because Flolan is not stable at room temperature and has to be refrigerated, the pump has to be refrigerated, the supply of drug has to be refrigerated when the patient is out and about. It's been nice that the treprostinil has come along. So treprostinil is more stable at room temperature, and the pump that delivers that is smaller, allowing the patient to be more ambulatory. So for class 4 patients, we now have the choice of either treprostinil, which is Remodulin, which can be given by pump, or Flolan, which can be given by pump. One interesting development that started in Europe was, and is now approved in North America, is to give inhaled prostanoids. Now, the inhaled prostanoids, which that's iloprost or Ventavis, that has to be given every 2 to 4 hours, so it's cumbersome. But on the other hand, you don't have a pump, you don't have a central line, and this has been also shown to be very effective in treating patients with class 3 pulmonary arterial hypertension. So we have a spectrum of therapies that go from a pill to an inhalation to the IV pumps. And I also would be remiss if I didn't add that treprostinil, which can be given intravenously, can be given by subcutaneous infusion with a pump. So there are 2 formats by which that drug can be given. I think one of the choices that physicians like my colleagues, Dr. Gomberg and Dr. Rich, who run our pulmonary hypertension program, when they're faced with a patient and they're trying to decide which medication is best to use, one certainly looks at cost. Sildenafil at $12,000 or $13,000, the endothelin antagonist at $60,000, Flolan at $100,000. You look at efficacy. The trials are not perfect, and that most of them are not survival trials, but I think the expert consensus document published by the American College of Cardiology and the American Heart Association with Val McLaughlin as first author this year, both in CHEST and JACC, suggested that, and I agree with this, that either an endothelin antagonist or a PDE5 inhibitor can be used as first-line therapy. The issue of monitoring, though, is important. For example, there are black box warnings with the endothelin antagonists because, as a class, they elevate liver function tests, and in some cases, they can do this severely, and there have been rare cases where this can even be life-threatening or fatal. So that black box warning means patients need to continue to have their liver function tests monitored throughout the duration of therapy. That's continuously. Moreover, these drugs, the endothelin receptor antagonists, are teratogenic, and so they can't be used in women that are thinking of getting pregnant. Now, on one hand, we strongly discourage any PAH patient from getting pregnant because it's very risky to both the mother and the fetus, but should they get pregnant and they're on an endothelin receptor antagonist, that's a problem. The PDE5 inhibitors, which include not only sildenafil but tadalafil, don't have a black box warning. They don't require special monitoring tests, and they're probably similarly effective. So I personally believe that this may make them a simpler first-line choice, but there are other pulmonary hypertension experts that prefer endothelin antagonists. Moving to a subcutaneous infusion with treprostinil is a reasonable alternative. However, it still requires a fairly motivated patient to use the pump and receive the drug, and it's limited by the pain at the local injection site. That limits how much dose can be given. You could move to inhaled therapy if you are not getting adequate response to the oral therapy. The only problem with that, again, is the expense. So when you go to Ventavis, and there's now a special inhaler for that, it's more expensive and it requires more frequent therapy. And then moving on to the Flolan or treprostinil intravenously, that's usually for the sicker patients. There is something beyond the drugs, and of course beyond the drugs we have lung transplantation. The new algorithms for lung transplantation, which are mandated by law, unfortunately redistribute lungs in a way that really doesn't favor them going to PAH patients, and many more patients now are getting transplanted that have pulmonary fibrosis, for example. So although some centers have reported lower survival rates with PAH in the first year, overall I think most of us find that once you get past year 1, the survivals are actually fine in pulmonary arterial hypertension patients. So for someone who's failing drugs, I think transplantation is a reasonable option. I would just leave the listener with this. There are 2 competing meta-analyses out there in the literature which comment on whether any of these existing expensive therapies improves survival in pulmonary hypertension. One concludes that there is no effect on survival, but there is some functional benefit. The other concludes there's lots of functional benefit and there's probably some survival benefit. I think the truth is pulmonary hypertension trials have suffered from being too short and not using survival as an endpoint. Survival, of course, does not mean that we leave people on placebo with no therapy, but in left heart failure or in coronary disease, we've long used the randomized clinical trial with mortality as a gold standard and used major adverse cardiac events as a secondary endpoint. That's very valid.